Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
All right, let's talk about pneumonia. You know, it's not just one single thing. It's more like a war happening deep inside the lungs. And to win that war, you've got to pick the right weapon. So today, we're going to take a deep dive into the pharmacological arsenal we use to fight this really serious infection. We'll cover everything from the go-to antibiotics to some of the more specialized antiviral and antifungal drugs.
So here's our game plan. We'll start with a quick introduction to pneumonia itself. Then we'll get into the different types. The real heart of our discussion will be the antibacterial drugs, kicking things off with the beta-lactams and then moving to other classes. After that, we'll switch gears to look at antivirals and antifungals. And finally, we'll wrap up by looking at a few related infections just to round things out.
Okay, let's jump right in. The single most important thing to get your head around is this. Pneumonia is not a one-size-fits-all diagnosis. Choosing the right treatment comes down to two absolutely critical questions. What specific bug is causing the problem, and where did the person get infected?
So at its core, pneumonia is pretty straightforward. It's an infection that causes inflammation way down in your lungs. But, and this is a big but, the most important question for a clinician is, where did this infection start? This one question splits pneumonia into three big categories: community-acquired, hospital-acquired, and pneumonia in someone who's immunocompromised. And why is this so crucial? Well, because it allows doctors to make a really good educated guess, what we call empirical treatment, right at the start, before they even know the exact bug they're fighting.
All right, let's dig into these different types of pneumonia a little deeper. We'll start with the most common one you'll see, which is community-acquired pneumonia.
So, imagine a patient comes in and you suspect they have community-acquired pneumonia. The first thing you need to figure out is, just how sick are they? And that's where this handy tool, the CURB-65 score, comes in. It's a really simple mnemonic that helps you check for 5 key red flags. C is for confusion. Is the infection messing with their brain? U is for uremia, which tells us if the kidneys are under stress. R is for respiratory rate. How fast and hard are they breathing? B is for low blood pressure, which is a warning sign for shock. And the 65 is for age. Is the patient 65 or older? You get a point for each yes, and the higher the score, the more severe the pneumonia and the more likely it is they need to be in the hospital.
Okay, so who are the main culprits when it comes to community-acquired pneumonia? Well, you can think of Streptococcus pneumoniae and Haemophilus influenzae as the usual suspects. They're by far the most common. And that's exactly why the first-line treatment is often a broad-spectrum antibiotic, like a macrolide or a beta-lactam. The idea is to cover your bases and hit the most likely offenders. But you also have to keep in mind the atypical pathogens, bugs like Mycoplasma and Legionella. These guys don't play by the same rules, and they won't respond to those standard drugs. For them, you need a different plan, something like doxycycline or a fluoroquinolone.
Now, once you step inside a hospital, the whole game changes. The types of bacteria you're dealing with are just different. They're tougher. We're talking about hospital-acquired pneumonia now, and the pathogens are way more dangerous. You've got highly resistant organisms like MRSA and really tough gram-negative bugs, including the infamous Pseudomonas aeruginosa. So naturally, your treatment strategy has to be much more aggressive. You're bringing out the heavy hitters, powerful drugs like vancomycin, specifically for MRSA, and often you're using a combination of drugs, maybe a carbapenem or a specialized beta-lactam that can take down Pseudomonas.
So that brings us to our first big class of drugs, the beta-lactams. And honestly, these are the absolute workhorses of the antibiotic world. They're a true cornerstone for treating all sorts of pneumonia.
So how do these beta-lactams actually work? Well, it's pretty clever. They go after something that bacteria have, but we don't: a cell wall. Think of the bacterial cell wall like a brick wall holding everything together. Beta-lactams work by blocking the enzymes, the transpeptidases, that act like the mortar holding all the bricks together. So when you take away the mortar, the wall can't be built properly. It becomes weak, it loses its structure, and pretty soon the whole bacterial cell just bursts. It's a really direct and effective way to take them out.
Now, the beta-lactam family isn't just one drug. It's a whole group with different branches. You've got the famous penicillins, like amoxicillin. Then there are the cephalosporins, which are really versatile. And for the really serious infections, we have the carbapenems. These are the big guns. But here's the catch. Bacteria are smart. They fought back by developing an enzyme called beta-lactamase, which is basically a weapon designed to destroy our antibiotics. So what did we do? We got even smarter.
We started pairing the antibiotic with a beta-lactamase inhibitor, like clavulanic acid. You can think of it like a bodyguard that takes the bullet for the antibiotic, letting it go in and do its job. Of course, as effective as they are, beta-lactams aren't without their downsides. The side effect everyone knows about is hypersensitivity, or what we commonly call an allergic reaction. GI issues like diarrhea are also pretty common. Now, a more serious concern, especially with the really broad-spectrum ones, is that they can wipe out the good bacteria in your gut, which can open the door for a nasty infection called C. difficile colitis. And then there are some less common side effects, like changes in your blood cell counts, kidney issues with some penicillins, and very rarely at super high doses, even seizures.
Okay, so we've covered the beta-lactams, but they're not the only players in the game. Let's look at some of the other crucial classes of antibacterials that we use for these kinds of infections.
All right, next up, the fluoroquinolones. These drugs use a totally different strategy. Instead of attacking the cell wall from the outside, they go right for the bacteria's command center, its DNA. Think about DNA as a tightly wound-up ball of yarn. To copy it, the cell has to carefully unwind it, make a copy, and then wind it back up. Fluoroquinolones block two key enzymes, DNA gyrase and topoisomerase 4, that are in charge of all that winding and unwinding. So by jamming up that process, they completely stop the bacteria from being able to replicate.
Now, these are seriously powerful drugs, and that power comes with some pretty significant warnings. You've got your usual GI and central nervous system side effects, things like nausea and dizziness. They can also make your skin really sensitive to the sun. But the big one, the one we really worry about, is their effect on connective tissues. This can cause tendinitis, and in some cases even lead to a tendon completely rupturing, especially the Achilles tendon. And that specific risk is exactly why you just don't use these drugs in pregnant women or in kids.
Let's move on to the macrolides. You've probably heard of azithromycin. The target for these drugs is the bacteria's protein factory, which is called the ribosome. What they do is they bind permanently to one part of that factory, the 50S subunit, and basically throw a wrench in the gears. The whole protein assembly line just grinds to a halt. And if the bacteria can't make proteins, it can't survive, and it certainly can't replicate. Okay, cotrimoxazole is a fantastic example of what we call pharmacological synergy. It's a combination of two drugs that work together to be way more effective than either one could be alone. Here's how it works. Bacteria need to make their own folic acid to build DNA. This drug hits that production line with a 1-2 punch. First, the sulfamethoxyazole component blocks an early step. Then, the trimethoprim component blocks a step further down the line. By hitting the pathway at two different spots, you get a much more complete shutdown. It's a really smart design. So let's just quickly run through a few other key antibacterials. You'll notice a theme here. A lot of them are protein synthesis inhibitors, just like the macrolides. For example, tetracyclines and aminoglycosides both go after the protein factory, but they hit a different part, the 30S subunit. Clindamycin also hits the protein factory at the 50S subunit, and it's particularly great against anaerobic bacteria. And then there's vancomycin. It's another drug that attacks the cell wall, but it does it in a different way than the beta-lactams, which is exactly why it's our #1 choice for fighting MRSA.
All right, let's shift gears completely. Because as we know, not all pneumonia is caused by bacteria. Especially when you're dealing with patients who have weakened immune systems, you have to think about viruses and fungi. And these pathogens, of course, need a whole different playbook when it comes to treatment.
When you're treating viral pneumonia, you have to be incredibly specific. Unlike broad-spectrum antibiotics, these drugs are like precision-guided missiles. For a virus like cytomegalovirus, or CMV, which is a big deal for transplant patients, you'd use something like ganciclovir. For the flu, you have drugs like oseltamivir, which stop the virus from spreading from cell to cell. And for SARS-CoV-2, you have drugs that inhibit key viral enzymes like nirmatrelvir/ritonavir. The point is, each drug is designed to exploit a very specific weakness in one particular virus.
It's a similar story with fungal pneumonia. The treatment has to be very targeted. If you're fighting an invasive aspergillus infection, you need the big guns, like voriconazole or even amphotericin B. For something like Candida, a simpler drug like fluconazole might do the trick. But here's a really interesting little fact, a real clinical pearl. There's a type of pneumonia called pneumocystis jirovecii pneumonia, or PCP, which we see a lot in patients with HIV. Now, it's caused by a fungus, but guess what we treat it with? The antibacterial drug cotrimoxazole. It's a weird exception, but it just happens to work perfectly against that fungus's folic acid pathway.
Okay, to wrap things up, I just want to quickly touch on a couple of related infections just so we can see how their treatment compares to pneumonia.
First, let's talk about a lung abscess. This is a really nasty complication where the infection is so bad it actually creates a pocket of pus right in the lung tissue. A common cause is when someone accidentally breathes in bacteria from their mouth, what we call aspiration. And the bacteria in your mouth are often anaerobes, meaning they don't need oxygen to survive. This is key because that specific detail points us right to our drug of choice, clindamycin, which is fantastic at killing those anaerobic bugs.
And finally, let's make a really important distinction between pneumonia and acute bronchitis. They both make you cough, sure, but that's where the similarity ends. Bronchitis is inflammation of the big airways, the bronchi, not the deep lung tissue like in pneumonia. And here's the absolute key takeaway. The vast majority of acute bronchitis cases are caused by viruses. This is so important for what we call antibiotic stewardship. It means giving antibiotics is not only useless, but it's the wrong thing to do. They simply don't work on viruses.
So we've walked through this incredible arsenal of drugs we have to fight pneumonia. But we have to remember, this is a constant arms race. For every new drug we develop, the bugs we're fighting are working around the clock to develop resistance. It's happening every single day. And that leaves us with a really sobering final thought. As the pathogens evolve, how do our strategies have to evolve too? What new approaches will we need to come up with to make sure we're still able to treat these infections effectively, not just tomorrow, but for generations to come?